I hope you can see my screen and
Yes.
that you can hear me.
Yeah.
Okay. So good morning again, and thank you very much for your kind invitation. I've been asked to talk about the Italian approaches to Sydenham's Chorea. So I will try to make an overview of the data available about the management of this condition in my country. As you know, Sydenham's Chorea is a condition that is diagnosed on a clinical ground and as a part of acute traumatic fever, and its diagnosis requires a clinical diagnosis of acute traumatic fever according with Jones criteria, and Jones criteria are different according with the expected incidence of this condition in a specific geographic areas. So it is critical to know the exact frequency of Sydenham's Chorea and acute traumatic fever in each country to know which clinical criteria should be applied to answer an accurate diagnosis. However, just few studies investigated this topic in Italy, and they are quite recent, but referring to different periods of time, and as you can see in these tables, most of them reported an incidence of acute traumatic fever that was above the threshold for considering the regions investigated as intermediate or high risk countries. So, according with available evidence, Italy should be considered an intermediate risk country, where the less strict high-risk criteria should be applied to avoid underdiagnosis of Sydenham Chorea and acute traumatic fever in general. However, the incidence of Sydenham's Chorea was highly different in these studies, and Chorea was found to occur in a very variable proportion of these cases, from 5 to 33% of the children diagnosed with acute traumatic fever. However, the question is if these data are actually reliable, if we can trust this data. All incidence rates in these studies have been retrospectively estimated, and no surveillance studies has been conducted as differently from the UK. And population studies were relatively small, and each study referred to small provinces or regions, and which were geographically scattered, and with total lack of knowledge from a very large part of Italy, such as southern and insular Italy. And also the studies from largest populations covering largest parts of Italian territory were based on this shared diagnosis, and no information was available about the diagnostic pathway and diagnostic criteria applied. So we don't know exactly if these diagnoses were correct or not. So one point is that the epidemiology of acute traumatic fever in Sydenham's Chorea is almost unknown. But how frequent is Sydenham's Chorea as a neurological emergency, as a presentation in the emergency department or to acute neurology services? In a retrospective studies of children admitted to 6 pediatric emergency rooms over 2 years. In 6 pediatric emergency departments, we found that 36 cases of Sydenham's chorea were diagnosed, accounting for 14% of all acutely presenting children with hyperkinetic movement disorders. According with this study, Sydenham's chorea was the second most common cause of acutely presenting movement disorders after primary tic disorders. In other countries, similar studies have reported very different results, with a quite lower frequency of Sydenham's chorea among children with acute movement disorders. However, it should be noticed that these studies have been conducted in different settings, more specialized settings than emergency departments, such as child neurology services or pediatric movement disorders clinics. So one explanation can be that not all children with Sydenham's chorea are referred to these highly specialized services, and in most of the cases they are treated by general pediatricians or rheumatologists, and they are not referred to movement disorder specialists or to child neurologists. The information that we have about the clinical presentation and management of Sydenham's chorea in Italy are largely due to this large retrospective multicentric cohort that has been recently published, and that was recruited from 16 Italian centers who collected information about 171 cases of Sydenham's chorea, with providing very useful information about clinical practice in Italy. Authors found that body distribution of chorea was generalized in most of the cases, and that carditis was highly prevalent in this cohort. And about treatment choice, treatment regimens used, this cohort demonstrated how Italian centers are prone to use immunomodulatory treatments in Sydenham's chorea, with a frequency that is much higher than what has been observed in other countries such as the UK. As you can see, about 40% of the patients receive corticosteroids alone, and another 40% of patients are treated with a combination of corticosteroids and symptomatic agents, and only a minority of patients are treated with symptomatic treatment alone, or receive no specific treatment apart from antibiotic prophylaxis. Symptomatic treatment choices also were extremely variable. There was no specific, no clear difference in the use of anti-seizure medications or dopamine receptor blocking agents, but a lot of molecules have been prescribed, and also molecules that are not usually listed as antichoric agents, suggesting that perhaps the confidence of each specific physician is the most important factor in the choice of the molecule, rather than expert recommendations. Corticosteroids used in Sydenham's chorea is one of the most controversial topics in the management of this condition, but we can say that Italian physicians are quite prone to prescribe these drugs to their patients, as testified by many studies reporting this experience from Italian centers. As you can see, there are many retrospective case series that have been published in the past, also in recent years, reporting the various steroid regimens used in this condition, with some judgment about their good efficacy that, however, was not based on high quality evidence. So to summarize, we can say that Italian physicians are very prone to prescribe corticosteroids, and more than 70% of Italian patients with Sydenham chorea receive steroids, even if evidence supporting this regimen is limited and of low quality, and also the regimen choice is highly dependent on physicians' experience and background. Clinical presentation of Sydenham's chorea in Italy is really heterogeneous, but one important finding from this cohort is the high prevalence of non-motor symptoms, including neuropsychiatric disorders that have been reported in about half of the children at the disease onset. And this is similar similar to the results we saw earlier from the UK, with a high prevalence of mood disorder and anxiety. Another important factor that I would like to highlight is the relapse risk. It is usually said that Sydenham's chorea is a monophasic disease, but it is not true for about 10% of the patients, according with our findings, with about many children who experience further relapse of chorea, mostly in the first months after disease onset. And even if this data should be interpreted cautiously, it seems that an older age at onset and the need for treatment with symptomatic drugs increase the risk for a relapse. However, these data are based on a retrospective investigation and are not exactly reliable. However, our approach to diagnosis and management of Sydenham's chorea in our institutions is based on its clinical assessment through the demonstration of Jones criteria of acute traumatic fever, and through investigations that are useful to rule out alternative causes of chorea. As a rule, we suggest you to perform in every children with new onset chorea of unknown cause a brain MRI and autoimmune assessment to exclude other potentially treatable causes of chorea, such as antiphospholipid syndrome, and also rare but treatable inherited disorders that may present with acute or subacute chorea, such as Wilson disease. So we usually perform in every children referred for chorea plasma ceruloplasmin dosing. And also we suggest to perform further investigations if Jones criteria are not fulfilled. So if a positive and certain diagnosis of rheumatic fever can be done. in these cases, lumbar puncture and screening for autoimmune and viral encephalitis or for inborn error of metabolism is required. About treatment, in our institution, we usually treat patients with steroids at presentation, at disease onset, with oral prednisone in mild cases, or with an intravenous cycle of methylprednisolone in severe or moderate cases. And we usually consider symptomatic treatment as an add-on therapy to be reserved to patients with poor or slow recovery with immunomodulatory treatment and moderate to severe disability related to the movement disorder. In terms of treatment of relapses, we usually suggest to reconsider diagnosis in every children who present with a relapse of chorea, with performing another brain MRI and reassessing for autoimmune conditions. But again, we usually treat relapses of Sydenham's chorea with corticosteroids if the last steroid cycle was earlier than 6 months at the time of the relapse, or if already 2 cycles of steroids have been performed, or if relapse occurs in the first 6 months from onset. We usually treat patients with intravenous immunoglobulins. This is just one explanatory case that I would like to share with you of a young girl who was admitted in May 2020 at the emergency department for left-sided involuntary movements with a subacute onset that generalized in the following days, with a progressive worsening leading to speech difficulties and gait disorder. Her neurological examination was demonstrated a bilateral chorea with moderate to severe impairment, and her general examination showed a systolic heart murmur. Clinical investigation demonstrated echocardiographic signs of rheumatic heart disease, and a brain MRI was normal. Antistreptolysin titer was elevated, so a diagnosis of Sydenham chorea was made, and screening for alternative causes was negative. So she was treated, as I said before, with methylprednisolone, and a short treatment with haloperidol was added because of the severity of the presentation. And she was also treated, of course, with antibiotic prophylaxis and with symptomatic treatment for her rheumatic heart disease. However, despite a fast improvement in the following weeks, she experienced a relapse about 3 months after the onset, that was treated with intravenous immunoglobulins due to the recent steroid treatment, and she recovered, but she suffered from another relapse a few months after, that was again treated with intravenous immunoglobulin, this times in addition with methylprednisolone, because symptoms were highly invalidating. And she experienced a third relapse about 10 months after the second episode, that was effectively treated with intravenous immunoglobulins. So many questions are still open at this point. We don't know exactly which are the correct indication to immunomodulatory treatment, including both steroids and intravenous immunoglobulins. do not know yet what are the optimal steroid regimens in terms of type of molecules and duration of the treatment, and the same is true for intravenous immunoglobulins. We don't know yet if repeated cycles effectively prevent relapses, and how long should be these cycles. And there is also poor knowledge about the most effective symptomatic treatment. Which molecules has the best safety and efficacy profiles, also considering the risk for neuropsychiatric associated symptoms. And another important open question is the relevance and frequency of residual motor and non-motor symptoms in patients who experienced in the past Sydenham's chorea and who recovered. Just to conclude, we in Italy, Sydenham's chorea and acute rheumatic fever incidence is poorly studied. So we do not have reliable data about their epidemiology. Sydenham's chorea assessment and treatment are highly heterogeneous, also within centers. So patients treated in the same center frequently receive different treatments. And there is a strong propensity in Italy towards steroid treatment and immunomodulatory treatment in general. The awareness about psychiatric comorbidities and non-motor features is increasing, but they are likely underestimated and undertreated and under-recognized. So we do really need a surveillance studies, a nationwide surveillance study, and some attempt to standardize our clinical practice in terms of diagnostic and therapeutic protocols in order to answer reliable evaluation of potential pitfalls in our clinical practice. Thank you very much for your attention and for your invitation again.
Thank you very much. That was extremely interesting. Do we have any questions from the group? Adrian?
As I said at the start of the meeting, your own Italian data shows that treatment with steroids and IVIG doesn't actually make any difference either to the functional outcome or to relapses, but yet you're still doing it. Is that because you feel that there is some other benefit that is not seen in the data, or for some other reason?
I think most of the reports suggest that steroids are not effective in preventing relapses or in reducing the residual symptoms, but that steroids may be helpful in achieving a faster recovery. Probably this is the only benefit that has some poor evidence, but still some evidence. And I'm not sure this is the right way of thinking about treatment of these conditions. There are so many things that we do not know yet, but I think this can be an actual goal of treatment, so achieving a fast recovery. And some data from the past suggest that steroids are helpful in this in achieving this goal. However, it should be demonstrated with studies with more quality, but I'm not sure that this is feasible in the short term. In terms of treatment with immunoglobulins, the evidence is still poor, but in our experience, it is extremely helpful. It is usually reserved to patients who have relapses or severe symptoms, but the empiric experience seems to suggest that they can be helpful. I don't know what's your opinion about this.
Thank you. I'll pass you over to Michael, but I think Dr. Michael Eyre will be showing some data that steroids maybe does help with reducing relapses in the future. So, but I'll pass on to Michael first.
Thank you, Adrian. Michael?
Yeah, I was very interested in your data on relapses, Giacomo, because the rate of relapses, I think we saw clinically and from other research, seems relatively low in Italy compared with other experience. And I just wonder whether the steroid treatments that you're routinely using could be responsible, or whether it's something to do with the methodology of the retrospective reviews, which are simply missing relapses because they don't go back to the neurology centers. They maybe get managed elsewhere. I don't know what you think about that.
I think both options are possible. I think there is probably a bias due to the retrospective nature of the studies, and I think some relapses have been missed. This is very likely, but it is also possible that a wide use of immunomodulatory treatment, also prolonged immunomodulatory treatment, because many centers prescribed very long steroid treatment may had some influence on the rate of relapse. The problem, in my opinion, is that we lack a clear definition of relapse for Sydenham's chorea, because in my experience, many patients do not have a full recovery after chorea. Some mild, very mild, and not disabling symptoms persists, and it's sometimes difficult to say if is a true relapse of an autoimmune disease or a fluctuating course of mild symptoms. I'm referring to, for example, young female patients that have disease onset before puberty and who experience an aggravation of symptoms with puberty, or when they start taking estrogens for contraceptions, and this is a relapse. This is immune mediated. I don't know. I don't think so. But this is another topic, and also timing of relapse is an open question. So if a relapse occurs after 3 months of steroid treatment, during tapering of the steroid, is a relapse or not? I'm not sure about this definition, and this retrospective cohort do not help in clarifying these points, and this is a major pitfall in our understanding of this condition.
I think that's really interesting. I think we found the same within the Scottish study around just understanding that word relapse and what families felt that word meant, because quite often it was the extremes in the presentation and the behavior, and when you unpicked it to get the actual physical symptoms of the chorea, I think there was only one of our cases that had current chorea at the time, but it's families' perception of what actually Sydenham's chorea is and what's important for them and what's important in the treatment they receive from the professionals around that understanding of the word relapse as well. So it is a really, really interesting point. Michael, you had your hand up, and did you pop it down? Would you like to ask a question?
No, I took it down. I think the response covered what I was going to ask.
Lovely. Okay, and I think Adrian sadly had to leave the group just now, but he's left his hand up, so we'll just ignore that for now. Tamsin, Oana, do you have any questions, or anyone else in the group have any questions? Tamsin?
I have one.
Go on, I must have read your mind there, sorry.
Yeah, I am aware that part of one of the slides at the end, you had, so one of your questions was already that's around the assessment of non-motor symptoms. So when I think in the psychological or neuropsychological symptoms, we're talking about the emotional ability and everything. So I'm quite aware that was already part of your questions. What is the assessment here? I was reflecting on the case study of the 12-year-old girl, and you said that she had, I think it's like full or comprehensive neuropsychological. And in my mind, I was instantly thinking, is there an assessment tool that you are using? Is it like a questionnaire, or did you mean that she was seen by a psychologist? Because I think there's a huge variety, but I was curious with that case, what was the assessment?
Oh,
if you have
usually we perform a standardized neuropsychological assessment at first, control after discharge from hospitalization, that encompass some screening for intelligence, like a fluid intelligence test, nonverbal test, and executive functioning. And then we also administer questionnaires to investigate neuropsychiatric comorbidities, and a trained neuropsychologist perform a structured interview for psychiatric symptoms. And then we, according with the results, we continue the follow-up. So I should say that we do not repeat on a regular basis this overall assessment, but just according with symptoms and result of the first assessment. And probably we should repeat the same full assessment at regular intervals, but in most of the cases we are not able to do it on a regular basis. And in my experience, non-motor symptoms in the course of the disease become the most disabling and important part of the disease, and I think they are really under investigated. And I'm not sure that the data that I showed suggesting a gradual decrease of neuropsychiatric symptoms along with the disease course is actually what occur in most of the patients. I'm not sure.
Yeah. Well, thank you. Just one of the things I'm curious about, and I don't know if there is any data suggesting that, but might be from listening to young people's stories. I was reflecting on Callum's story about some difficulties being present before the onset of Chorea, and part of me is thinking, could it be the emotional ability? The more subtle changes, emotional changes, before we actually see the striking features, the Chorea. But that's just something I'm curious about.
I totally agree. This is another major pitfall in this practice. So we usually lack any baseline evaluation before onset of motor symptoms, and I agree that in many cases, people come to consultation and parents report that some hyperactivity or attention deficit or emotional liability was always been part of the picture of their child, and you don't know how to what extent you can ascribe symptoms to the Sydenham's chorea and or not. This is another.
It's very interesting, because the Scottish study was exactly the same, and we used the kiddie sides, but we started with a timeline, and it was a timeline leading up from birth till now, and the symptoms that definitely came out were the spikes in emotional presentation, but separation anxiety, just not being able to separate from the parent, and then the rapid decline in school. Most of them had a real drop in their ability in school, and it's how you assess and judge that. Was that part of normal development? Would that have happened anyway, or is it linked to the Sydenham's? And it's a really, really important point. But ours again was just a small study, but in that study you could clearly see, I think, the separation anxiety, the ADHD, and the emotional resilience of the child. It's interesting. Eureka's got a hand up. Have you got a question for
Yes.
Dr. Garone?
Oh, thank you. We were part of a study in Sweden for IVIG because they thought Rebecca had pandas to begin with. And we've seen remarkable results actually with IVIG. But my question is, we have only received like short spouts of steroids. Do you think steroids should be part of the treatment, or could you only just, get IVIG? Because this time she has had 2 relapses, and this relapse she has had 6 IVIG treatments, and she has improved, but she's not fully recovered. So I'm just wondering.
And are the side effects of that quite great as well?
Sorry?
The side effects, do you feel the side effects from
We
the
had
treatment?
yeah, we had really horrible side effects to begin with. Actually the first, I think, 7 treatments, 8 treatments possibly, but the last few treatments we've had no real side effects. She had a treatment yesterday actually, so that's why I'm at home with her right now.
I'm not sure if I correctly understood. The question is about treatment of Sydenham's chorea, or about pandas?
Yeah. No, they have now decided she has Sydenham's chorea. So yeah. So I'm just, because it's really rare in Sweden, and I'm not sure, it's difficult to get treatment, correct treatment, I guess. And so I'm just wondering if you would, recommend steroids as well, because we've had a week of steroids and it hasn't really done much difference.
I think nobody can answer this question with an evidence-based approach. What I can say that in Italy, steroids are widely used for this indication, even if they lack any specific recommendation or guidelines supporting this practice. So we can't say if they are actually effective, but we use them. We use them in many cases. In my opinion, that can be part of the treatment of children with Sydenham's chorea, but there are also a lot of side effects that should be cautiously taken into account before deciding which treatment is appropriate. And usually, I don't think they have they are more effective than intravenous immunoglobulins.
Okay.
This is not, however, this is not studied, and there are no evidence that can be used to answer this question in a proper way. This is the problem.
Yeah, thank you so much.
No, thank you both. Thank you very much for your presentation. It was just fabulous. And actually, interestingly, we're coming on to Michael Eyre now. That he is looking at some of the questions that are being raised from our last presentation. So, Michael, I'm going to hand over to you.